TopMedTalk.
We are here at the final day of EBPOM-USA 2018 Masters Course, a Perioperative Care Practicum in Atlanta, Georgia. My name is Desiree Chappell, and I'm host of the Roundtable, TopMedTalk, and I'm here this morning with my co-host Vicki Morton. She is Director of Clinical Quality Outcomes for Providence Anesthesia in Charlotte, North Carolina. And we're also joined this morning by Dr. Andrew Spector. He is an assistant professor of neurology at Duke, and he has an interest in sleep disorders and obstructive sleep apnea. Andrew, thank you so much for joining us this morning.
Thank you very much for inviting me.
Yeah,
I'm happy to be here.
Good. We appreciate you sitting down with us. So I think we should just jump right into it because I think you have some really great information to share, and we're really looking forward to listening to your session later today. So it seems like you're pretty passionate about obstructive sleep apnea and sleep disorders and causing problems for the perioperative patient. Can you tell us a little bit about your background and how you were interested in that?
Sure. Well, my background is, like you said, neurology, but I did a fellowship in sleep medicine, and I focused my clinical practice in sleep medicine for the last few years. And I find it something that's critically important. Treating sleep disorders affects everything else in life. It affects quality of life. It affects health, heart disease, strokes, kidney problems, eye problems. The list of consequences from sleep apnea is exceedingly long, and in the perioperative space, specifically significantly higher risk of complications following surgery for patients with untreated sleep apnea. So this is a population, I think, that should be targeted a little more heavily for treatment to improve perioperative outcomes.
Yeah. Can you tell me how many people are dealing with sleep apnea in the U.S., for example?
Well, the trick is that it's probably wildly underdiagnosed, and that's part of our reason for targeting this population. A lot of times people get scared. They say, I don't want to use a CPAP, or I don't want to have a sleep test, or they come up with all sorts of excuses as to why they don't pursue it. But when we look at the perioperative population, this is a population very dedicated to improving their health. They want the best surgical outcomes. So we're hoping that we'll get a lot better data as to maybe the true prevalence of sleep apnea when we start targeting a screening population like this. Yeah,
so you're going to be talking about the process of pre-operative optimization for this patient group. So what does screening look like for this subset of patients?
Yeah, so current practice is when patients come and have a preoperative visit, they'll get screened with some sort of questionnaire. Often they use the most famous one is probably called Stop-Bang, which is an 8-point questionnaire that's used in the preoperative world to screen for sleep apnea. And depending on the score they get on a 0 to 8 scale, they're more or less likely to have sleep apnea. From there, many times what happens is the preoperative screening clinic will pass that information on, and the patients will get monitored more carefully in the hospital to look out for these worse outcomes for patients with sleep apnea. But that might be as far as it goes. And so our goal is to enhance that process so patients can go in and get screened and tested and treated all before the surgical date.
So question for you. And I understand that this likely is common practice, but help me understand why any preoperative clinic would do a Stop-Bang or any other evaluation, maybe pass the information on, maybe not, and then stop there. What's the point of doing the evaluation if there's no action item?
Well, there are short-term and long-term outcomes from this. So in the short term, you're going in for surgery, and the anesthesiologists and the nurses in the hospital can monitor for these obstructions and these apneas and treat on the fly. And that will get someone through their hospitalization reasonably well. If it's known that they have sleep apnea or highly suspicious for sleep apnea, they can be monitored and narcotics are reduced and increased watchfulness, and we can do a reasonable job. But at that point, they move out of the perioperative space, and that information gets lost. And it's a trouble with transition of care. Who's going to take up the patient who had a screening test that was positive but was never actually even diagnosed? And what happens from there? And we're trying to close that loop.
Is that part of the pre-op clinic that you all have started there at Duke?
Yeah, so what we're doing is we're going to screen, test, treat, and then offer the first follow-up.
Oh, great.
So that they go all the way through CPAP through their first follow-up before being transitioned back to either primary care or to sleep medicine.
Wow, that's fantastic.
That is fantastic.
Let me ask you about the stop bang, because you hear, that is the most common that you hear. What is the sensitivity of that test? Is it in your experience feel like it's a pretty accurate and sensitive test and can pick up, or do you feel like people slip through the cracks on that particular?
Well, that depends
tool?
on the threshold of the screen. So. If you had a threshold of 1, if you scored 1 point, it's going to be very highly sensitive. You'll pick up by everybody with sleep apnea if you only use a 1. So it really isn't a matter of the tool, it's a matter of the threshold of the tool that you're using. So you can set your particular threshold at a 3 or a 5, and the higher you set, the less sensitive it is. You'll miss more people. But you trade that for specificity. So if you use too low a threshold and you start testing everybody with a 1 or a 2, you're going to have a whole bunch of negative tests, and then it becomes financially unfeasible.
Cost prohibitive.
Right. So we don't want to screen that. So there is a sweet spot. It seems to be, depending on your particular values, 3, 4, 5, in that range. Yeah. At a 5, I'm trying to remember the number, and I think it's somewhere around 80% sensitive still, but it's more specific. So it's picking up many of your people, but you will miss some the higher threshold you use.
Yeah. Is there a particular patient population that you feel that this doesn't do an accurate job of catching?
Well, so when we look at what stop bang uses, they use things like BMI, that's the B in bang, and neck circumference, and gender, and age, and that will pick up a lot of your classic patients. Mm-hmm. Because the middle-aged obese male is your stereotypical sleep apnea patient. But we see a lot of sleep apnea in other populations. We see people who are thin, who have strong family histories of sleep apnea. So for anatomic reasons, they've developed sleep apnea, and it runs in their families. It has nothing to do with their weight. Or another population, say a young woman with polycystic ovaries. Mm-hmm. Now, even if she manages to catch the BMI threshold, she's not going to catch gender, she's not going to catch age, maybe not neck circumference, and it'll be easily missed. So there are populations that really won't be captured by stop bang.
So what are you doing, or what's going to be part of your clinic, the pre-op clinic, to catch those patients?
We've talked to the nursing staff about this, and there are not that many of those. Young women are very unlikely to have sleep apnea. Mm-hmm. It's a very specific case when we talk about PCOS, polycystic ovaries. And they know, essentially from just an education standpoint and a training standpoint, that patient needs a higher level of scrutiny for sleep apnea. Yeah. But it's not. There's no questionnaire that's going to capture everybody that way.
Yeah. Vicki, I'm curious, in your pre-op assessment, are you all using stop bang or any other assessment tools?
I don't do typically the pre-op assessments. I'm more involved post-operatively. I know we do OSA screening. I'm not exactly sure what tool we use. But what I do know, and why I asked the question earlier, is often when I'm going through these charts, I see an OSA positive, but then I don't see any type of action. They go to the floor. There's no additional monitoring. They may have gotten some narcotics. And so I wonder, why did we even do the screening if we're not actually doing something about it on the back end? And I often wonder, is that common across the country? Are we doing screenings, but then for these surgical patients not following through with action after that?
Yeah.
I suspect it is very common. I can't speak to the practices around the country, but that's my suspicion. And recently, and it was 2016, the Society for Anesthesia and Sleep Medicine published guidelines that basically take it a step further and do advocate for a more aggressive approach. And that's based on many, many studies showing the harms of sleep apnea in the perioperative world. So that society has published guidelines saying we really ought to be treating with CPAP in the hospital. And for those patients who are tested and treated, there's no reason they shouldn't continue treatment after that, because their sleep apnea almost certainly didn't go away.
So the patients that do have sleep apnea and are already diagnosed, do you recommend that they bring their own CPAP machines with them to the hospital, or do you provide that?
Absolutely. We do tell everybody, and that's part of our initial screen. So before we would do something like a stop bang to screen for sleep apnea, the first question is really, do you already know that you have sleep apnea? And if you already know you have sleep apnea, are you using your CPAP? Do you have any problems with CPAP? And if that's the case, we have an embedded sleep tech who can help improve compliance prior to surgery. So they can go from the nursing and the NPs and the PAs who are seeing the patients right down the hall, talk to a sleep tech, get their mask issues sorted out, get them compliant, teach them about why they need to bring their machine and how important it is to remain compliant through the surgery.
Yeah. So speaking of preoperative compliance, how does that affect outcomes? I mean, if you have someone that is following the regimen and utilizing that CPAP machine before they come in, is that affecting outcomes on the other side? Or
absolutely, the data on that suggests that those with treated sleep apnea are really no different than those without sleep apnea in terms of outcomes. It's the untreated sleep apnea where you see substantially higher risk of complications, but someone who has been treating their sleep apnea and continues to do so is really no different than someone who doesn't have sleep apnea in the first place.
Just for the listener's sake, can you talk about some of the complications that occur with obstructive sleep apnea postoperatively?
Depending on the study you look at, it could be increased risk of reintubation or developing atrial fibrillation. I saw there's some studies on increased risk of shock afterwards and cardiac arrest. But not mortality. So they've never shown that you're actually higher risk of dying, and I think it's a testament to how good our hospital care is. We address these issues when they arise. Of course, it'd be better not to have them in the first place, but we haven't shown a mortality difference, but certainly increased morbidity associated with it.
Yeah.
Also, beyond that, so could you also talk about what are the, for untreated OSA, obstructive sleep apnea, if somebody goes years undiagnosed or untreated, what can that possibly lead to?
Well, that's one of my favorite questions, and I go through this with my patients all the time, and it's a scary, scary list. And so it ranges from heart attack, stroke, diabetes, high blood pressure, heart failure, chronic pain, depression, glaucoma and other causes of blindness, erectile dysfunction, waking up to urinate more often at night, car accidents are more common, and I could probably go on. Dementia, if I didn't mention that yet. So it's a very long and horrible list.
Wow, that is horrible.
It really is.
So this is what's great about what we're doing in the perioperative world, because this is a population that may have gone unnoticed until they needed surgery. So we can capture them and potentially change many, many other aspects of their health.
So this is really interesting, and this is why I love coming to conferences at BOM and hearing all of these great discussions. You know, these are things we do and listen and hear about in our everyday, right? I can tell you that I look at if patients are OSA positive or not and what happens postoperatively, and then I kind of go about my day, and I then deal with the opioid issue, whatever. But this really makes me stop and think that we need to be doing more for our patients with screening, treating, really making sure we're following up with them, because we could be helping them tremendously.
And I think one of the limits right now, one of the reasons that this doesn't happen more is logistical. I think a lot of sleep centers around the country are probably like Duke, especially at academic centers. There's a delay. So if you're seeing a patient 1 or 2 weeks before surgery, and I know sometimes it's even shorter than that, but if it's even 1 or 2 weeks, there's no chance that you're going to get a patient into a sleep lab, get a sleep study, get it interpreted, get the CPAP ordered, and do all of this before the surgery. And so part of our work is expediting this so that you can use home sleep apnea testing, have it embedded in the clinic. So you go from stop bang of 5 to a home sleep test down the hall, and that sleep tech who's embedded there can set you up with a home sleep test on the spot. We can get you diagnosed within 24 hours.
Oh, that's fantastic.
And then we can pass that information on to our local medical equipment suppliers who are partnering with us to get CPAPs faster and are prepared to ramp up their business as we ramp up ours to keep up with the demand for CPAPs. So when we expedite the process, we can solve a lot of the hurdles that have been in place for why this doesn't happen more.
So you said a home sleep test. Can you explain that?
So a home sleep apnea test, and we would like to call it that because it really only looks for sleep apnea, whereas an in-lab sleep study can look for many other sleep conditions. These are home sleep apnea tests because they're just a positive or negative, do you have sleep apnea or not, and that's all we're looking at. They're actually relatively simple tests, and they only screen for oxygen desaturation and airflow obstructions, and that's a very limited test. So technologically, it's not as good as an in-lab sleep study, but for our purposes, it actually will do a great job of catching the people we really need to catch. There is a high risk of a false negative study with a home sleep test, but if you're really on the border of whether or not you have sleep apnea, that's not the critical population we're looking for. If you have moderate to severe sleep apnea, the home sleep test is going to be really good at picking that up. And then we'll know we can get these people treated, and we don't have to wait for a bed to open up in the sleep lab to get this done.
Wow, that sounds like a great program.
So one last final question, because I know everyone wants to know, the information's great. It's a great process. How did you build a financial case for this?
So it all starts with the idea that we're going to save the hospital money on the back end, right? So we're going to reduce complications of surgery. We're going to reduce length of stay, because that's another thing they've shown. So we're going to save money on that end. Home sleep apnea testing isn't terribly expensive. And with volume, you can actually get it to balance out. We're not anticipating huge revenue stream from the home sleep apnea testing. It should be about revenue neutral. So if you can make a project that's revenue neutral and improves patient outcomes, it's a no-brainer.
Yeah.
We shouldn't be losing money. It's not going to be a huge money maker, but that's not our primary purpose here.
Yeah. Well, Dr. Spector, thank you so much for sitting down with us this morning on our final day here at EBPOM-USA. I think that as everything the trend of everything we've been talking about this weekend, it really is a testament to improving population health and overall health of the patients that we're taking care of and the communities around us. So thank you so much for everything you shared, and we can't wait to listen to your session later today.
Well, this was great. Thank you very much.
Thank you, Dr. Spector.
Great. Well,
Thank you.
Tune in to our live broadcast throughout the day at TopMedTalk.com, and please be sure to follow us on your favorite social media platform, Twitter, LinkedIn, Instagram, Facebook. We're all there at TopMedTalk, and you can find our podcast recordings on our website and on your favorite podcaster, TopMedTalk.
TopMedTalk.